The commonest type of involvement of the brachial plexus in injury is the complete palsy. It is very easy to say the diagnosis as a complete palsy or a global palsy or a flail upper limb. But is the treatment the same for all the patients with this type of injury? Are there no differences between the different patients while planning the treatment strategies? Yes, there are. Patients differ in factors like age, the time between the injury and the surgery, whether they are preganglionic or postganglionic, and if so, which roots are preganglionic and which roots are postganglionic lesions, the status of the joints, the concomitant injuries present in the involved upper limb, and the presence of pain plays a major factor in deciding the treatment protocol in different patients. As far as the age is concerned, we need to remember that the more advanced the age, the lesser is the nerve regeneration potential. The second thing to remember is the time between the injury and the surgery. It can be divided into 4 different slots between 0 to 3 months, 3 to 6 months, 6 to 12 months, and more than a year. We have already seen the complete clinical examination. We need to remember that complete paralysis of the serratus anterior and deep neck muscles suggests a C5-6-7 avulsion. Horner syndrome suggests that there has been a C8 and T1 avulsion. If the spinae are spared, it suggests that's an infraclavicular lesion, that is a postganglionic level lesion. When we clinically examine those dermatomes in which the sensation has been lost and sweating is present in those areas, it's most probable that the roots have been avulsed. If the skin is dry, it is most probable that the roots have been ruptured. And central pain is suggestive of avulsion of the roots. Various clinical studies have shown that rupture of the upper roots and avulsion of the lower roots is more common almost in 50% of the cases. This most probably can be explained by the fact that the upper roots have got more ligamentous supports at the level of the foramina, so the chance of avulsion of the upper roots is quite less when compared to the lower roots. Similarly, in 25 to 30% of the patients, it is avulsion of 4 roots with one ruptured root, usually one of the upper roots. And complete avulsion of all the roots from C5 to T1 has been noted in about 20 to 25% of the patients with the total palsy. Patients also differ with respect to the other injuries that they have sustained, like multiple rib fractures, shoulder joint injuries, lower limb injuries, and VIC forearm. For instance, if they have multiple rib fractures, we have to reconsider using the intercostal nerves as nerve transfers. Before planning the treatment protocol, we need to assess the status of the joints in the totally paralyzed limb. The passive range of motion of all the joints must be examined starting from the shoulder up to the finger joints. We also need to assess the cause of the stiffness, and this stiffness should be treated first. Before we make a plan for the reconstruction, we need to know what are the goals that we need to achieve. In other words, what is it that we want to achieve in that particular patient? The first important thing is elbow flexion, then it is shoulder stability, elbow extension, then finger flexion and finger extension. However, though the goals that I have mentioned are true, the order that I mentioned just now are not absolute. There are 2 methods of planning reconstruction priorities. It may be from proximal to distal, that is, neurotize the proximal muscle first, then go to the distal muscles. The next type is the neurotization from the distal to proximal. In the first type, it starts with shoulder, then elbow, then finger, whereas the distal to proximal starts with finger and elbow, and finally the shoulder. In the proximal to distal reconstruction, the nerve reconstruction is the mainstay of management of the shoulder, elbow, and finger, whereas in the distal to proximal reconstruction, the nerve reconstruction is reserved only for the shoulder, maybe, but the other, that is the elbow and fingers, are reconstructed with other procedures, like instance free functional muscle transfers. All the nerve reconstructions can be done in a single stage, but the distal to proximal reconstruction requires multiple stages. So it is obvious that the proximal to distal reconstruction is preferred in patients who have presented very early. The rehabilitation period of the proximal to distal reconstruction is much longer, that is about 4 years, whereas the distal to proximal reconstruction is usually complete by about 2 years. So, we can select highly intelligent or motivated patients for the proximal to distal reconstruction. But if it is going to take 4 years, what is the need for doing a proximal to distal reconstruction? Even though it takes time, the proximal to distal reconstruction is supposed to yield better results as far as the shoulder, the elbow flexion, finger flexion are concerned, though finger extension is not very good. In distal to proximal reconstruction, the results of elbow flexion, finger flexion and finger extension are average, but the shoulder is usually fused. Before we plan the strategies, we shall see what are all the available donors for nerve reconstruction. First is the roots, which happens in case of rupture. The proximal roots are available. The next is the phrenic nerve. Third is the spinal accessory nerve. Then we have the intercostal nerves from 2 to 7. We always have the contralateral C7 root, which can be used as a transfer using a vascularized ulnar nerve graft. When we have so many donors available, we need to put these donors onto recipients to get the resultant function. How do we choose the available recipients? We all know that the brachial plexus starts in the roots and ends in the branches. So the nerves that we are going to use for transfer can be used to any part of this complete system. So how do we decide where to put in the donors? It all depends on what you want to achieve. If you do a nerve transfer to the C5 root, you get shoulder abduction, deltoid function and hand sensation. On the other hand, nerve transfer to the C6 roots will give you all the above along with elbow flexion. A transfer to the C7 root will give us elbow extension, finger extension and hand sensation. A nerve transfer to the C8 root will give us finger extension, finger flexion and shoulder adduction. And nerve transfer to the T1 root will achieve hand intrinsic function along with finger flexion. Nerve transfer to a slightly more distal target, that is for instance the upper trunk, will get us shoulder abduction, deltoid function, hand sensation and elbow flexion together. Similarly, nerve transfer to the middle trunk will achieve elbow extension, finger extension, hand sensation and latissimus dorsi along with pectoralis major function. Nerve transfers to the lower trunk will achieve finger extension, finger flexion, hand intrinsic function, sensation on the arm and forearm and also the sternal part of the pectoralis major. When we have lesser number of nerves for transfer, we can choose smaller targets, like for instance if we use the anterior division of the upper trunk, we will get back hand sensation and elbow flexion. However, nerve transfer to the posterior division of the upper trunk will get us shoulder abduction and external rotation. More distal transfers to the lateral cord can get us hand sensation, elbow flexion and the clavicular part of the pectoralis major. Nerve transfer to the medial cord will achieve innervation of the sternal part of the pectoralis major, the forearm flexors, forearm extensors, hand intrinsic muscles and the sensation on the arm and forearm. Neurotization of the posterior cord alone will achieve wrist extension, thumb extension, finger extension, deltoid function, function of the latissimus dorsi muscle and shoulder rotation. Finally, nerve transfers can be done to individual nerves like the suprascapular nerve, the biceps, the brachialis, the axillary nerve, the median nerve, the nerve to long head of biceps or the musculocutaneous nerve, etc. So, comparing the proximal neurotization and the distal neurotization, the proximal neurotization is usually going to be to the trunks or the divisions or the cords, whereas the distal neurotization is going to be closer to the target. The advantages of proximal neurotization are that the proximal nerves are more powerful in that groups of muscles are neurotized. And distal neurotization, the advantage is that there is less dissection, there is no scarring where you have to dissect the trunks or the cords, and there is no need for nerve grafts, and quicker rehabilitation can be achieved. The disadvantages of proximal neurotization are difficult dissection of the trunks or cords or the roots, and we may need longer nerve grafts and longer operating time, and obviously longer rehabilitation period. Whereas the distal neurotization, we may have an iatrogenic injury because we'll be transferring some nerve. There may be a deficit there. More proximal neurotization can be done in all types of avulsion or rupture of the brachial plexus, whereas distal neurotization is usually ideal for C5 or C5-6 avulsions and in hand intrinsic palsy. So we need to choose the recipient according to what we want to achieve. We also need to consider the time since injury and the time needed towards recovery. For instance, if a patient presents within 3 months of the brachial plexus injury, if he is less than 50 years, you can plan a proximal to distal reconstruction of the nerves. If he is more than 50 years, it is better to do a distal to proximal reconstruction. If he has presented between 3 months and 6 months of the injury, we can do a proximal to distal nerve reconstruction for the proximal group of muscles like the shoulder and the elbow, whereas we can plan a distal to proximal reconstruction for the distal muscles. For the elderly patient, it is better to plan a distal to proximal repair. If the patient is presented later after 6 months, if he is a younger individual, you can plan a distal to proximal reconstruction or a free functioning muscle transfer. If the patient is more than 50 years, it is better to plan a free functional muscle transfer or even salvage procedures. If the patient is presented very late or reconstruction has done but has not worked, it is better to plan free functional muscle transfers for younger individuals, and for elder individuals we can plan salvage procedures. Now let us consider different scenarios. A scenario where all the roots are avulsed. Now experts in the field have already devised protocols for such situations. We do not have to stick exactly to these protocols, but we need to use this as a base which can be modified to suit our patients. Chuang has described the use of the spinal accessory nerve transferred to the suprascapular nerve to achieve shoulder abduction, the phrenic nerve transferred to the posterior division of the upper trunk for shoulder rotation, intercostal nerves to the musculocutaneous nerve for elbow flexion, and contralateral C7 to the median nerve for achieving finger flexion. As far as achieving elbow flexion is concerned, it can be done with transfer of the spinal accessory nerve using a nerve graft or with intercostal nerves without using a nerve graft. Studies have shown that using the spinal accessory nerve gives a good strength of elbow flexion, and using the intercostal nerves gives superior sensory recovery and improved pain control. As far as using intercostal nerves is concerned, these transfers must be performed in younger patients and preferably within 6 months post-trauma. Done much later, the results are usually poor. Using the intercostal nerves for elbow flexion, 3 intercostal nerves can be used to the musculocutaneous nerve if the patient is less than 6 months post-trauma. If the patient is between 6 and 12 months post-trauma, transfer of 2 intercostal nerves to the musculocutaneous nerve to achieve elbow flexion, and 2 intercostal nerves to innervate a free functioning muscle transfer for finger flexion can be done. For late presentations, 2 intercostal nerves to innervate a free functioning muscle transfer for elbow flexion, and 2 intercostal nerves for a free functioning muscle for finger flexion. Neurotization for finger flexion is usually productive if done when the denervation time is less than 6 months. When one route is available, usually the C5, the protocols are as follows. The quality of the available route must be assessed. All the reconstruction depends on the quality of this route. When the stump is very small, it can be grafted to the posterior division of the upper trunk to achieve shoulder function. When the stump of the C5 is of good quality, it can be grafted to the lateral cord to achieve both elbow flexion and hand sensation. Experts have formed their own protocols. Alnott, for instance, uses the spinal accessory nerve to the suprascapular nerve and the available C5 route to the anterior division of the upper trunk to achieve elbow flexion. Nagano et al. Use the C5 to the posterior division of the upper trunk to get shoulder function and transfers of the intercostal nerves to the musculocutaneous nerve for elbow function. When 2 routes are available, usually the C5 and C6 routes, they can be used individually. From C5, grafts can be applied to the upper trunk, and from C6, grafts to the posterior cord to achieve elbow, wrist and finger extension, and the contralateral C7 can be used to neurotize the median nerve for finger flexion. When 3 routes are available, usually the C5, 6 and 7 routes, the spinal accessory can be transferred to the suprascapular nerve, or according to Chuang's protocol, the C5 can be grafted to the suprascapular nerve and the posterior division of the upper trunk. The C6 can be grafted to the median nerve and the C7 to C7 itself. Here, three intercostal nerves can be used to neurotize the musculocutaneous nerve for achieving elbow flexion. But this means we'll be needing many grafts. We can harvest both the sural nerves, the sensory branch of the radial nerve, and the vascularized ulnar nerve graft can also be used. Now we consider a rare situation when all the roots are ruptured and all of them are available. Here, anatomical reconstruction can be done. But we must remember that reconstruction of the lower trunk is worthwhile only when the patient is young and when the interval between the trauma and surgery does not exceed 3 months and when the nerve graft required is short. According to Thatte's protocol, there are 4 stages of reconstruction for a pan palsy. In stage 1, the plexus is explored and whatever roots are available are used for neurotization. The spinal accessory is transferred to the suprascapular nerve and the contralateral C7 is used either to the lateral cord to achieve biceps and pectoralis major or the posterior cord to achieve deltoid, triceps and extensor carpi radialis longus function. So by the first stage, shoulder stability, elbow flexion or elbow extension are achieved. In the second stage, which is 3 months following the first stage, free functional gracilis transfer is done using the thoracodorsal vessels and the intercostal nerves to achieve finger and thumb flexion. One intercostal nerve is used for the triceps if C7 had been given to the lateral cord. So by the second stage, finger and thumb flexion and elbow extension are achieved. In the third stage, which is 1 year after the second stage, wrist fusion is done. And in stage 4, tendon transfers to improve hand function for grasping and shoulder fusion if the shoulder is unstable. Summarizing the procedures for elbow flexion, the phrenic nerve can be transferred, the intercostal nerves can be transferred, or contralateral C7 also can be transferred when it is neurotized to both the median and the musculocutaneous nerves. Summarizing the procedures for shoulder function, anterior transfer of the spinal accessory to the suprascapular nerve or the posterior transfer or the transfer of intercostal nerves to the axillary nerve can also be done. For elbow extension, either intercostal nerves for direct transfer to the nerve of the long head of the triceps or the contralateral C7 can be used when it can be transferred simultaneously to the median nerve and the triceps branch. But since this nerve transfer does not neurotize synergistic muscles, it may not be very effective. As far as elbow, wrist and finger extension are concerned, the intercostal nerve seems to be the relatively optimal donor for the triceps, and using the same to reconstruct these three functions is quite reasonable and effective. As regards achieving finger flexion, contralateral C7 nerve transfer is the most commonly used method for restoring function in the median nerve. Free functioning muscle transfers have a very important role to play in pan palsies. Double free functioning muscle transfer described by Doi for achieving elbow flexion and hand functions. The triple muscle transfer described by Tu et al. Using 2 gracilis and 1 adductor longus for finger extension, finger flexion and elbow flexion. The indications for these free functioning muscle transfers are either primary distal to proximal method of reconstruction or in failed previous nerve transfer surgeries. Secondary procedures are done in late cases when nothing else is feasible, like for instance tendon transfers using the available muscles like the trapezius to stabilize the shoulder and wrist arthrodesis to improve the posture, and free functional muscle transfer can always be attempted. Having made a plan, we need to now decide the timing. It can be done in the emergency situation when the wound is an open wound. It can be done after the 3rd month when there is no clinical sign of functional restoration or electromyography signs of denervation are present, or clinical and EMG signs of recovery of distal branches instead of proximal muscles. In cases of iatrogenic etiology, it needs to be explored early. Now we need to consider the presence of pain in brachial plexus injuries, especially avulsion injuries. There are 4 types of pain: nociceptive, neuropathic pain, complex regional pain syndromes and phantom limb pain. Whatever be the type of pain in brachial plexus injuries, it is important to treat it because otherwise all the reconstructive procedures that we may do may fail. The neuropathic pain is the most characteristic pain in avulsion injuries, which is chronic, persistent, constant, burning sensation with throbbing pain and paroxysmal discharges, especially even upon gentle rubbing of the affected areas. Treatment of the pain can be non-surgical or surgical. The first step in non-surgical management is tricyclic antidepressants like amitriptyline, but with regular ECG surveillance. The second step is the combination of the above-mentioned drug with anti-epileptic agents like gabapentin or pregabalin. The third line of management is lignocaine 5% patches applied to the painful area. And lastly, transcutaneous electrical nerve stimulation can be done. There are four basic options for the surgical management of neuropathic pain: decompression, reconstruction of the nerves, neuromodulation, and ablative procedures. Neurolysis is a decompression procedure which releases the entrapment of the nerves in the scar, relieving the pain. Nerve reconstruction procedures like direct suturing or grafts or nerve transfers minimize the incidence and severity of neuropathic pain. The third method is the neuromodulative procedures. This procedure actually applies electrical impulses to different areas of the central or peripheral nervous system to block the transmission of any nerve impulses that are interpreted as pain. Procedures like the peripheral nerve stimulation, cervical spinal cord stimulation, pulsed radiofrequency, and motor cortex stimulation come under the category of neuromodulative procedures. Ablative procedures aim to destroy the posterior horn spinal cord neurons that start to fire in an abnormal way, causing pain. The dorsal root entry zone ablation procedure destroys the neurons located in the posterior horn of the spinal cord, as we have described, and this destructive procedure can be applied only when no residual upper limb function has to be preserved. Thank you for watching.